Hello, my name is Michael VanPelt. I'm going to talk about fifth metatarsal base fracture management. This is my conflict of interest statement, which I have none. Here are my goals and objectives for this talk. So I'm going to talk about fifth metatarsal fractures. Just in general, metatarsal fractures can be broken up into head fractures, neck fractures, shaft fractures, or base fractures. Metatarsal fractures and fractures in general are common injuries amongst motorcyclists, often can occur from direct crush also, but can present from inversion or type injury resulting in avulsion type injuries, but they can also come from overuse injuries. Fifth metatarsal fractures are a common fracture among athletes. The incidence in college football players is about 1.8%. And when we look specifically at proximal fifth metatarsal fractures, those can be broken down into avulsion fractures, Jones fractures, and proximal diaphyseal fractures. Now, avulsion fractures, the mechanism when they occur acutely is usually from traction from the peroneal brevis and the plantar aponeurosis. That is the short plantar ligament of the plantar fascia that it inserts on the base of the fifth metatarsal. Now, a true Jones fracture that occurs acutely usually is about 1.5 centimeters from the most proximal aspect of the fifth metatarsal. The mechanism of injury is usually from an adduction force applied to forefoot when the ankle is in a plantar flex position. And proximal diaphyseal fractures typically occur from stress injuries. You see it in running sports. And often these patients can have prodromal symptoms in athletes. And this is just from chronic repetitive stress. Often this is associated with a cavus foot type. And here you can see this sort of distinguishes itself from other fifth metatarsal base fractures in that you can see there's cortical thickening and perching of the lateral cortex. This is indicative of a chronic repetitive stress injury because the body has undergone this load and repetition on that lateral cortex, and you get a response with hypertrophic bone formation and then fracture. So typically you see what we call an acute on chronic type injury. So when you want to classify, fractures at the proximal fifth metatarsal, typically we break them into zones. And those zones being 3 zones, with zone 1 being at the metaphysis. And typically here you see avulsion fractures. The zone 2 fractures are typically the true Jones fracture. That's at the metadiaphyseal junction. Usually these fractures will sort of go into the articulation between the fourth and fifth metatarsal. And then you will have the proximal diaphyseal fracture. Often, like I said, is from chronic repetitive stress, but can occur also acutely. So when you break these zones up, usually zone 2 and zone 3 are typically bad injuries. Zone 1 injuries typically do pretty well. And so when you say, hey, let's subdivide these into what's bad and what's good, and which fractures have a predictable outcome, usually the proximal metaphyseal fracture typically has a predictable outcome. Typically these will heal. Now, and those will heal typically with weight bearing in a hard sole shoe or boot. Now, if there is retraction of the avulsion fragment with significant displacement, of course, these can be treated differently because the outcome may change when there's a large amount of displacement. But if there's minimal displacement, typically these fractures are consistently do well. Now, when you break up the other two fractures into one and combine them into one category, that is a metatarsal fracture. These will typically somewhat act similarly. And also our treatment usually changes when we see these fractures. And you're talking about a significant amount of non-weight bearing in your layperson or treating athletes a little bit differently who want to return to sport with early surgery. But why is this that we treat them differently, and why are zone 2 and zone 3 injuries different from zone 1? Typically, this is because of vascular supply within the bone. And the vascular supply in the fifth metatarsal becomes very sparse in the region of that zone 2 and zone 3 area. You have one nutrient artery that comes in there and it provides significant blood supply to the diaphysis. But as you go proximally, it becomes a little sparse at that metatarsal-diaphyseal junction. And you have avascular structures that attach at the proximal aspect of the fifth metatarsal, that is the peroneal brevis, and also peroneus tertius. It also provides an insertion point on the fifth metatarsal. And these contribute to a zone where there's a hypovascularity. So if you look at these and look at the natural history of fifth metatarsal fractures in the general population, with the bulging fractures, typically they will heal with immobilization in 4 to 6 weeks. And this was sort of reported in Clapper's study and reported in the Clinical Orthopedics and Related Research Journal back in 1995. This study was done in the U.S. Naval training facilities in San Diego and also Corpus Christi, Texas. And they were looking at these fifth metatarsal fractures in trainees. And what they found is that Jones fractures, usually at 8 weeks, treated with 8 weeks of non-weight bearing in a cast or boot, transition to weight bearing, had 79% healing rate. And the average time to union was about 21.2 weeks radiographically. And diaphyseal fractures, of course, typically would heal in a plaster cast or boot in 4 to 6 weeks. So this is one of those fractures that I mentioned previously, and where you have significant displacement of that zone 1 injury, where you'd say, hey, I'm going to treat this along the same lines as I would treat any other fracture with significant displacement, in which I would go and reduce it and fix it and stabilize it so you can get normal healing and return to sport or activity. So when you go back and you look at fractures, these in the treatment for fifth metatarsal fractures in athletes, typically with zone 1 injuries, hey, we let them go. We let them weight bear as tolerated in a hard sole shoe or a boot, and typically you have a predictable outcome in which they will heal. But when we get into the zone 2 and zone 3 areas, and then our treatment changes when we talk about the general population, and then athletes want to return to sport. And so typically with these zone 2 or zone 3 injuries, with the zone 2 injury, you're in the general population. In zone 3 injury, typically you're going to say, hey, I'm going to immobilize you, put you in a short leg cast or boot for 6 to 8 weeks. And this is sort of equivalent to a TORG 1 acute fracture, and 90% of these will heal with immobilization for 6 to 8 weeks, and then gradual return to weight bearing, protected in a boot, and then back into a shoe. But when you're talking about an athlete, and we're talking about sports today, trying to get the athlete back to the field, the court, or whatever their sporting activity is. Typically, you want to uh, try to get them back going sooner and get them back mobile and healed and stabilized so they can return to their sport. And so with zone 2 and 3 injuries, often we will discuss immediate surgery, operative treatment. And these equate to toric 2 injuries in which you have a delay in healing. And once again, this x-ray here shows an acute on chronic type injury where you have hypertrophy of the lateral cortex. Here you can see there's a fracture at that metatarsal diaphyseal junction, and that fracture is extending into the articulation between the 4th and 5th metatarsal base. And there's a little bit of sclerosis at the fracture site. And so this would also be considered a toric 3 type injury. And you will want to prevent this from happening, right? So, especially in athletes this will delay their return to sport. They decondition, they're inactive, and so that's not good for that athlete. So we want to get them back going again. And typically we will offer surgery immediately. In regard to shaft fractures, again, weight bearers tolerated hard sole shoe or boot. So when we're talking about surgery, one of the most common ways of treating this is using a percutaneous fixation method. Of course, you can use a single screw. Some people like to plate, and there are various versions of plating systems with hook plates or other specific anatomic plates for the 5th metatarsal. But the majority of treatment for 5th metatarsal base fractures have moved to a single sort of percutaneous large diameter screw. When we're talking about large diameter screws, we're talking about a 4.5 to 5.5 or 6.5, and there's specific systems out there that are available specifically for this fracture. You can use cannulated screws, or you can use a solid screw. It's sort of a dealer's choice and what you prefer as a surgeon. But of course, we all know that cannulated screws have a hollow core and have a higher failure rate with 3-point bending. And so a solid screw has been preferred, especially when you're talking about someone returning back to sport and with high demand, high impact on that injury site. So the approach this usually discussed in regard to addressing this percutaneously is the high and inside approach. Typically, you're about a centimeter superior from the inferior cortex, and also centimeter is medial to the lateral cortex. And so if you look here, I have my K-wire, and it's going down the shaft there of that metatarsal. Usually I'm proximal, at least a centimeter, 1.5 centimeters proximal to that inferior cortex. As you can see here, my animation of my screw, how it goes in. And that also, you have to remember, there's a declination in regard to the metatarsals. And so being very high and coming down in a downward approach will land you right into that shaft of that metatarsal. And then if you look here from a sort of an AP perspective, and so you're talking about being inside, being just medialized to the lateral cortex, about a centimeter and a half, and hugging the tissue. And usually we start a little bit proximal, and I'll show you an example of that in a clinical setting. You can see here, we typically want to go down that shaft here, because what can happen is if your entry point is too far laterally, that screw can angulate over to the medial cortex, the metatarsal, or it can shift that proximal fragment slightly medially if it's in the wrong position. You see here. And there's, like I said, there's specific screws designed now, some that are chamfered, so they will not impact the cuboid. And I'll show you an example of as we go on in this lecture of a screw that's non-chamfered, how it can erode or sort of cut into the cuboid and cause somewhat of a defect here. Clinically, this is what we're looking at when you have the patient on the table. Very small incision for injury. Typically, I'll make that small stab incision, bluntly dissect with a hemostat, and go distal to the base of that fifth metatarsal. So as you can see here, with this system, it's a cannulated drilling and tapping system, but a non-cannulated screw. You can see here, placing that, and then there's a slight chamfer to it, so it does not erode or cut into the cuboid and cause erosion or a defect in the cuboid itself. And you can see here, this is what you see, and what you see here in clinically when you're operating in the OR. You can see me placing that screw. See there. You can see how proximal I am to that metatarsal base, coming down to land it right into that proximal. And medial to the lateral cortex, proximal portion of the fifth metatarsal base there. Here you want to have a good setup. As you can see here, usually I use a large C-arm. Some people choose a smaller C-arm in which they can maneuver themselves. I typically don't want to do two jobs at once. I want to fix the fracture and not have to work and maneuver C-arm at the same time. So I have a radiology tech there who's maneuvering the C-arm for me, and I perform the placement of that screw. As you can see here, using that high and inside approach. Now, typically, the screw doesn't have to go down the shaft that far. You only need threads to be just proximal to that fracture site. You don't need to go completely down the shaft, but sometimes the screw lengths may not be that short, and depending on the size of the foot, if it's a shorter foot, the screw may go down and the threads may be a little bit further down the shaft. And also, I was showing you and telling you about the screw head, how it can erode into the cuboid. As you can see here on this oblique view, that head of the screw is somewhat eroding into the cuboid. So there are site-specific screws for this to stabilize the fracture and have a little bit of a chamfer cut or bevel so that it will not erode into the cuboid. Chuck Pai Wong reported on 32 Jones fractures and reported a 78% satisfaction rate, and return to work was about 4.1 weeks, and return to sport was 23 weeks after fixation of Jones fractures. It had bony union noted at 6.2 months, and the complication rate was 21.9%. And it had 29 proximal diaphyseal fractures with a satisfaction rate of 79% after treatment, and return to work was 3 weeks, and return to sport was 18.2 weeks, and bony union was noted at 8.4 weeks, and complication rate was 20.7%. And this is somewhat of an example of they use a cannulated 4-0 screw to fix these fractures. Rick Wright reported on refracture rate with fixation of fifth metatarsal base fractures, and reported a rate of less than 10%. And average time to refracture was about 4 months after fixation. Bob Anderson also reported on this and reported a refracture rate of 12%, and average return to play was 8.7 weeks. And they recommended getting a CT scan to document healing, especially when you're talking about an athlete who's trying to return to sport. You want to document if there's healing, because if there's not healing, you want to hold them back and wait till you see some bony union. Also, you want to try to use a larger diameter screw. I, on average, use 4.5 or 5.5 up to a 6.5, especially in larger individuals. I'll also incorporate orthosis or shoe wear modifications in order to help protect that site. And if there's a refracture, you consider exchange of the hardware and use a larger diameter screw. So what are the outcomes when you're talking about proximal fifth metatarsal fractures in athletes? And so if you're talking about the highest level of soccer in the United States, which is Major League Soccer, MLS, they reported it was reported on 21 fractures and 18 players in MLS during that study period. They had a mean time to radiographic healing of fifth metatarsal fractures was 8.5 weeks. And you're talking about the number of fractures were 17, and the mean time to return to play was 11.1 weeks out of 19 of those patients. They had 21 fractures out of the 20 patients, and 95% of the players returned to their sport. 18 players, so 4 out of that 18, that's 22% experienced refracture. And I think I made a mistake on what I said last. So it was 20 out of the 21 players had 95% of players return to sport. So this is all based off level 4 evidence. Of course, this is a case series, and these are professional players. So, it was also reported in a Polish professional soccer league, and Polish professional soccer players with a total of 21 players. And they subdivided the players into a group A and then a group B. Group A, and there were 11 patients in this group, had immediate percutaneous fixation, and they went on to return to play at 9.2 weeks. And they had a group B, and these were subdivided into those who were treated non-operatively and then re-injured themselves, refractured, and were converted to surgical patients. And their return to play was 17.5 weeks. And then there was another group, total of 4 patients who had non-unions and ended up having to have surgical repair. And they returned to play at 24.5 weeks. And so what they concluded is that weight bearing in a boot also at 2 weeks post-surgery does not delay fracture healing or hinder bone healing. But those who also too were treated immediately with percutaneous fixation returned to play in 9.2 weeks. Those who were treated non-operatively and went on to non-union, they had the longest course of not returning to play. So if you look at the outcomes of NFL players, it was reported in 25 consecutive NFL players on fifth metatarsal fractures, and these players were treated with screw fixation, bone marrow aspirate, and demineralized bone matrix injection, plus bone stimulator, plus custom foot orthotics, plus rehab. 67% of the players underwent operative fixation during their first 3 years playing in the league. 48% were diagnosed before or during their rookie first season, and return to play was 100% for all players. 80% were still playing at the time of the publication, and 3 players, that's 12%, had a refracture and required revision surgery. 9 players who underwent surgery from July to October, so that's about a regular season. and well, usually it goes on into November. So the average return to play was 8.7 weeks. The level of evidence from the study was, again, this is case series, level 1 evidence. This was reported by Bob Anderson. So how about professional basketball players? So the NBA had reported, in a study that was reported on the NBA and fifth metatarsal fractures, there were 10 professional basketball players. 7 players underwent percutaneous internal fixation and bone marrow aspirate concentration injection. 3 players underwent open bone grafting plus fixation plus bone marrow aspirate concentration injection. Radiographic healing was overall average at 7.5 weeks. Return to play was 9.8 weeks. And 3 athletes experienced refracture. And this was level 4 evidence, of course. Once again, it's a small case series, but this is some of the better evidence out there. And then when you put all of those studies together, then you can get a systematic review. This is a systematic review reported by James Calder and Andrew Roach. The majority of the evidence out there for fifth metatarsal base fractures is level 4 evidence. And so they reported that on the return to sport, based on all the studies and the accumulated data, was from 4 to 18 weeks. And acute fractures treated non-operatively, the union rate was 76%. And those treated operatively with screw fixation, they had a union rate of 96%. Those fractures that had a delay in union, that were treated non-operatively, the union rate was 44%. And those treated operatively with screw fixation, who had delayed unions, they had a 97% union rate. So those patients who had non-unions that were treated operatively with screw fixation, the union rate was 97%. So how about, the outcomes of management of fifth metatarsal stress fractures? So there were 37 professional football players who had intramedullary screw fixation of the fifth metatarsal stress fracture. They had 24-month follow-up. And what they found was the mean return to play was 10.5 weeks. The mean time to complete radiological union was 12.7 weeks. Return to play at 8 weeks or less resulted in a higher risk of delayed radiographic union. That was 24% at 3 months. Let me repeat that again. Return to play at 8 weeks or less. So if they return to play less than 8 weeks, that resulted in a higher risk of delayed radiographic union. And 24% was reported at 3 months. So this is level 4 evidence. Once again, it's a case series. And so, and basically what they're saying is that, hey, you need to extend that return to play a little bit longer than your normal 8 weeks. You have to slow that player down sometimes and hold them back before you let them go. Because it can result in this. As you can see here, this is a refracture of a fifth metatarsal base fracture that had been fixed previously with a large diameter cannulated screw. One thing is noted that this patient has some metatarsal adductus, as you can see on the AP view. And also, if you look at that foot on lateral, they have a significant callus foot, so they have pre-existing foot deformity. And this can contribute to why you see a failure of this fracture and a non-union. Because sometimes there's some pre-existing foot deformity, which leads to these metaphyseal diaphyseal fractures and stress fractures that have to be addressed and at least acknowledged and brought up to the patient. And you may have to incorporate additional procedures such as performing a calcaneal osteotomy, a Dwyer type osteotomy, or lateral displacing calcaneal osteotomy to try to reduce the hindfoot varus deformity, or incorporating a dorsiflexury wedge osteotomy of the first metatarsal in order to try to lower the arch to reduce plantar flex first ray, so you're not driving hindfoot varus. So some of these issues can be ignored, because sometimes if they're ignored, patients come in with this as a result. So here's another example of a 30-year-old female who presented me with a fifth metatarsal fracture. They were seen previously at our urgent care clinic and placed in a boot. As you can see here, there's a proximal diaphyseal fracture. Patient has a nice arch there. This patient, by the time they came to me, they were probably 6 weeks post-injury, and I told the patient, hey, we need to just continue the treatment of non-operative care and immobilization, short leg cast for a total of 3 months, and non-weight bearing. As you can see here, some cortication at the fracture site, and then went on to get a CT scan at 3 months to check for healing or union. There was no radiographic union, as you can see here, as I go through the CAT scan. So how I usually address this is when someone has a non-union, I use a technique that I learned during fellowship, in which I use a windowing type technique. And I place that window over the non-union fracture site, and I cut out a wedge of bone. And usually I will take a corticocancellous autogenous bone graft from the patient. I will go to the calcaneus and get that. So I will mark out my wedge. I will take out that wedge, you can see there. I will measure that, and you can see where the fracture line goes through it. I'll measure the height, the length, the depth. And what I'll do is I'll go back to the calcaneus, and I will use those exact measurements and take out the corticocancellous wedge out of the calcaneus, as you can see here. You see there distally at the fifth metatarsal there. I've taken that wedge out, and I've gone back to the calcaneus and removed the same measurements of a corticocancellous structural graft. And I will take that and I will fashion and make sure I will place it into that fracture site. So, and the reason why I do this is some people will just ream down the canal, drill and ream, which is an option. But if I see cortication at the ends, I want to resect and get nice bleeding bone at the fracture site. And often, sometimes after I've done that, there's a defect. And so that's why I choose to use a more precise rectangular type structural graft, in which I'm fashioning and controlling the size rather than just going into breeding and then looking at what I have left over and trying to go get what I need. I'm just planning ahead of time. I know how I'm going to resect, how much I'm going to resect, and I'm going to debride the ends. But sometimes after debriding to bleeding bone, you can resect so much and it shortens the metatarsal significantly. And I try to prevent that. And so that's why I use this windowing technique and place a window of bone of a structural autograft into the area. See that there? and then I'll use a plate over that and stabilize my fracture. There are various plates I use. This is just one example. There are also hook plates. I also use plates such as this. And so this is sort of my technique in addressing a non-union. Now, if it's an athlete, typically I will just ream down the canal and ream really well and drill and still use the percutaneous fixation method and place a large diameter screw. Now, if it's a refracture, then I will use this technique. If it's just a non-union, it was in an athlete, then I would just use the reaming method. Break up that fracture site and try to stimulate endosteal bone healing across the fracture site. You can see I took my graft. So some practice pearls in regard to this. One, with zone 2 and 3 injuries should be treated the same. Solid screw is preferred for fifth metatarsal fracture, especially in athletes with a high stress across the fracture site. High and inside approach is the preferred method of screw placement. And to address structural deformity, usually I use a cortical cancellous graft. And typically you want to keep athletes or hold them back a little bit longer before returning to play. Surgical stabilization of the metatarsal Jones fracture is often recommended for the athlete, as it is often associated with a low number of complications and a high rate of union than non-operative management. Thank you. If you want to reach out to me, you can. This is my information. I can be reached via this number or via email.